of Anesthesia and Critical Care Medicine at the Perelman School of Medicine at the University of Pennsylvania, and is the medical director at the Cardiac Center at the Children's Hospital of Philadelphia. Dr. Nicholson holds the Josephine Templeton Chair in Pediatric Anesthesia Education at the Children's Hospital of Philadelphia. Dr. Nicholson has spent her entire career for patients with congenital heart disease and is involved both in training the next generation of pediatric anesthesiologists and pediatric cardiac anesthesiologists, and also in attempting to answer some of the unanswered questions in this very difficult field. Today, she's going to share with us her experience about how to implement a successful enhanced recovery after surgery program. Thank you very much, Dr. Nicholson. Please.
Greetings, everybody. I'd like to preface my comments by thanking Mona and the other members of the organizing committee for inviting me to participate in this webinar. It's indeed a privilege to do so. And I send greetings to all from my colleagues at the Children's Hospital of Philadelphia. As you can see from the program, I was asked to talk to you on how to implement a successful fast-track program. But I've taken the liberty to change the title slightly to indicate how to implement a successful enhanced recovery after surgery, or ERAS program. And I made this change principally because over the last several years, fast track is starting to be replaced by ERAS for two reasons. First of all, an ERAS program is a much more comprehensive approach to perioperative care. And secondly, unlike fast track, ERAS has an obligation of showing improved value. Over the next 30 minutes, it's my intent, first of all, to define for you what we mean by enhanced recovery after surgery, to present a little bit of the background of ERAS, and to tell you why I believe that ERAS is an ideal platform to present in congenital cardiac care, to show you the cornerstones of such a program, to spend a little bit of time on program design, and then focus on implementation of such a program, including some of the barriers to implementation, and talking a little bit about what we just heard about was the ability to sustain, if you're fortunate to plan such a program and implement it, how do you sustain it for the long term, and how do you improve such a program if you have it? Like our last speaker, I'm going to present a little bit of the implementation data of the first ERAS program that was put together and implemented in the US by Dr. Roy and her colleagues at Boston Children's Hospital, and then conclude with some potential next steps. So what is an enhanced recovery after surgery program? Well, it is an integrated, multidisciplinary perioperative care model using evidence-based, multi-component protocols. So unlike some fast track, which refers principally to early extubation, an ERAS program has multiple components spanning the entire perioperative care of a patient. An ERAS program has 5 fundamental goals. The first is to reduce the variability in how we take care of patients. Second is to minimize the stress to the individual patient. Thirdly is to facilitate postoperative recovery. Also to improve the patient and family experience. And very importantly is to demonstrate an increased value. Such a program has to meet all these goals while at the same time not increasing morbidity and mortality, but ideally decreasing complications, i.e. morbidity and mortality. Since a significant component of such a program is to show increased value, I thought we'd spend a little bit of time talking about what is value. Well, value is simply quality divided by cost. And in a congenital cardiac program, quality is made up of 3 components: outcomes, safety, and patient experience. So in order to improve value, we have to increase the numerator and/or decrease the denominator, or both. So in order to improve outcomes, an ERS program focuses on accelerating recovery. And this can be done by using opioid-sparing strategies, not only in the operating room, but in the postoperative care. And opioid strategies were initially started in an attempt to enable patients to be candidates for immediate, defined as on the OR table, or early extubation. And most would agree to a definition of within 6 hours of completion of the surgical procedure. Over time, however, it's been shown that opioid strategies have other desirable consequences besides the ability to extubate a patient early after surgery. Other variables that accelerate recovery are resumption of enteral feeds early in the postoperative care, and removing lines, drains, and tubes early so that the patient can have early mobilization. Another variable that accelerates recovery and improves value is if the patient has a shorter length of stay in the ICU, the postoperative care, or both venues. Obviously, something that improves value is if there is reduced complications, and very importantly, one wants to improve the patient and family satisfaction. So what is the background of enhanced recovery? Well, this, like early extubation, is not something that is new. This was popularized in the early 1990s in adult surgical care of abdominal surgery. And the literature is full of successes in adult patients, and very recently, the ERS concept has been applied to non-cardiac pediatric care. But I would contend that congenital cardiac care is the ideal platform for such a program. Think about how we take care of patients every day. We come to work and care for patients with a highly functional multidisciplinary care team. And as we just heard in the last speech, there has been much success with individual components, i.e. early extubation, or an individual component of ERS. Over the past several years, congenital cardiac care has demonstrated many successful opioid sparing strategies, both in the OR and the ICU. And the last talk today will focus on dexmedetomidine, which I think has been a game changer in enabling a better application of opioid sparing analgesia and anesthesia. If your programs are like ours, we not infrequently have a higher demand for postoperative care beds, i.e. ICU beds, than we have available. So a strategy that would enable a more expedient, safe pathway from surgery to discharge may impart a better bed utilization in our hospitals. I'm trying to see where, there we go. So what are the cornerstones of an enhanced recovery after surgery program? Well, it's based on the fact that one has to have evidence-based protocols for each of the components of care. There needs to be multidisciplinary teamwork, and there needs to be continuous interactive reporting and reviews of adherence to the protocols. After review of the adherence or lack thereof, there will be new data to drive additional change. And the team really has to be ready to make iterative changes in the protocol. So what makes up a congenital cardiac enhanced recovery team? Well, it's the people that we work